Great. In this next module, we'll review investigator responsibilities. As you know, you're responsible for conducting the trial in compliance with the protocol that's been approved by your ethics board that we've generated and consistent with the terms of good clinical practice. One of your key priorities is to ensure that the subject that's been enrolled in the trial is safe and has been well protected. So their safety is of primary importance. As a principal investigator, or as a site investigator, or I'm also addressing any sub-investigators you may have, you're personally responsible for either conducting or supervising the clinical trial and patients in that trial. Now, of course, you're not going to do everything in the trial. And so we have a process which we've used in the Re-Energize trial. So if you worked with us in Re-Energize, this will be the same process of delegating authority. And I'll say more about that in a moment. I just do want to stress that it's important that when you're not physically present at the institution, either on holidays or at a conference, that as a site investigator, you have a sub-investigator that you've delegated your responsibilities for. If you're away and there's a person on trial, or the team is recruiting somebody to the trial and you're not physically present, that's a problem. And so please ensure that you've got adequate coverage when you're absent. You also will have to allow us or other external auditors to come to your site and do inspections. And that's just one way of ensuring that the trial is being done in a high quality way. This is the process by which we enable other people to participate to all of those duties, all of those trial tasks and responsibilities. We delegate to them, and there's documentation to support that. And you would have received these, you would have used them probably before in other trials that you participated in. And so we identify the person, their task, and their training, and their start and end date. And so we'll need those from you prior to initiating the trial. So what I want to say now really is what are the duties that the site investigator, the physician investigator, needs to do in this trial? Because again, everything else can be delegated to the research coordinators or other staff via that delegation of authority process. So the site investigators need to be involved in that process of determining eligibility of potential subjects that will be randomized. And again, we'll go over the eligibility criteria in the next module. Now I'm just trying to stress that, if the research coordinators are screening and they identify somebody, that the physician investigator or sub-investigator be involved in saying, yeah, this person's eligible. And we stress the importance of documenting that in the medical chart. And if you've got another templated way of doing that in your paper or electronic chart, that's fine. But if not, here's a suggested entry into your medical chart where you're identifying that the patient has been screened and consented, and Dr. So-and-so, was involved in confirming eligibility, date and signed by the research coordinator, or date and signed by the site investigator, him or herself. Okay, so that needs to be, if we were audited, there needs to be evidence that the doctor was involved in making that determination. The other role for the physician site investigator or sub investigator is in the SAE process, helping identify and assess the serious adverse events. And we'll talk with the research coordinators more later in a different module about the details of the paperwork. But at this level, I need the physicians, site or sub-investigators to help sort of determine if something untoward happened. Is it a serious adverse event that needs to be reported? And by serious, we mean anything that results in death, is life-threatening, requires hospitalization or prolongation of hospitalization, or results in significant or permanent disability or incapacity, or is a medically important event that has escalated treatment, led to more surgeries, etc. Now, if it is serious, we are only interested in serious adverse events that are unexpected. And that includes death. So we don't need to hear about every death. And for example, if a patient with severe burns comes in develops multi-organ failure and dies, from their injuries as expected because of the severity of them, that's don't get me wrong, that's serious, that's bad from their point of view, but from a reporting point of view, it's not unexpected. So the unexpected events are the ones we want to hear about. And in particular, if somebody comes in, has a bad burn injury, is recovering, they're probably late in their course with you, you're expecting them to do well. You come to work one day and they died overnight, and query sudden death syndrome from pulmonary embolism or cardiac something. Okay, that's obviously an unexpected event. It's serious. It would get reported to us. Okay, so I hope that's clear, that we're only interested in unexpected events, and the role of the physician is to help not only judge the expected or unexpectedness, but also then now the relationship to the study intervention. And typically in trials, when you look at drug trials, you're aware of the safety profile of said drug, or you look at the investigator brochure and you see the side effects. And so if you see that side effect, then you say, oh, it could be due to the vitamin or to the drug under study. Now with vitamin C, we don't have an investigator brochure. We have some sense of its safety profile. I've told you now across 2 trials, we see increased incidence of acute kidney injury, and we'll be watching for that as an outcome measure. So if it develops, it's not an unexpected event. In fact, it's a study outcome. In fact, it's part of the primary outcome. So it does not need to be reported. And so it'll be difficult to judge the expectedness if something else untowards happens. And if you are thinking this is due to the vitamin C, please make your thinking very transparent, because not only myself, but other members of the data monitoring committee will be reviewing your reasoning. So you're going to judge whether it's not related, unlikely related, possibly related, or probably related as per those definitions there. Just a little bit more on your roles and responsibilities, and just to, again, create that awareness that a patient may be withdrawn from the study or have the study investigational product stopped prematurely at their own request if they withdraw their consent. And that happened a few times in Re-Energize, particularly because if you had an awake patient who didn't like the taste of the slurry that we were giving them, it's really important that if someone is withdrawing from the trial, that we negotiate with them that we want to try and keep them in the outcome assessment, that we're just stopping the investigational product. Now, I doubt this will happen with vitamin C, but if it does, again, we're going to acquiesce to their demands, but we try and ask, well, is it okay if we continue to collect your data moving forward and capture, your study outcome with this data from the chart, and so that we can continue to collect their data. And of course, if they deny that request, well, then that's fine. We'll just censor them at that point. We're not asking for permission to keep their data from the point of randomization, because we did have consent to do that. But if they withdraw entirely at that point, then they'll just be censored up until that point. So they're still in the trial, you just will have truncated data. You may have the ability to withdraw people if you're concerned about safety, like we talked about. And there's a few safety concerns that will flag for you that may lead you to discontinue the study investigational product. And there are 4. We know from outside the ICU literature, so again, just to stress, in the more than 20 randomized controlled trials in sepsis, we have not seen any of these things, with the exception of the hypoglycemia one, which I'll perseverate on in a minute. But we know from outside of the ICU, high dose vitamin C over a prolonged period of time contributes to increased oxalate kidney stones. So vitamin C does increase the excretion of oxalic acid, and just the development of a stone and related kidney injury with a short-term infusion is not likely. But if you did see that, if that did happen perchance, then that you may attribute that to the vitamin C and stop the study product. Severe hemolysis, I'll say more about that in a second. Let me just label acid-base electrolyte imbalances, and refractory hypoglycemia. These are the other events that could occur. These are events of interest. We're tracking them in the CRF. So again, they're not SAEs because that would be an unexpected event. These are things that might happen, and we are capturing them as events of interest. But it's still, you can stop the product if they happen. Hemolysis occurs in the context of G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency. And I've got a little map of the world to show that this is extremely rare in North America, more common in sub-Saharan Africa and in Asia. And so to the extent that you have, immigration from people of sub-Saharan Africa or Asia, you may see patients who have this disorder. And when we talk about the eligibility criteria, we'll say if somebody has a known history of G6PD deficiency, then obviously they'll be excluded from the trial. However, if you don't know that they have that, and we're not asking you to screen for it because the prevalence is so low, if that's not part of your standard routine to screen for it, then don't do that. But if you develop hemolysis on the investigational product, then think about that as, oh, this might be somebody who has G6PD deficiency, and you would, at that point screen for that, as well as document it as an event of interest, as well as discontinue the vitamin C. So again, happy to entertain more questions about that at the end of this module. And then the last thing that I'll highlight as a potential safety issue is that vitamin C and glucose interfere with each other, and some of the point of care devices that we use to measure glucose will give you a false reading. And so it'll be, say, a false normal reading when in fact you're measuring both vitamin C and glucose. So the glucose is actually low. So you see this false normal reading when the glucose can be low. And so you see refractory hypoglycemia due to a false interpretation of the actual blood glucose levels. And so the way we overcome that is by not using non-validated measurement tools. By validated, I mean they've been validated to be safe and efficacious in the presence of vitamin C. Any core lab glucose measurement will be safe and valid. Most blood gas machines have been validated in the presence of vitamin C. And so if you're using a blood gas machine, just confirm that. And most glucometers, bedside point of care glucometers, are not validated in the presence of vitamin C, except for one made by Novo Biomedical. And so if you use a lot of glucometers and you don't have a one by Nova Biomedical, we can provide that with the strips. And so that becomes a point of conversation with you and Maureen, and she can arrange for the shipping of said device to your center. So the last thing I'll stress in terms of site investigator responsibilities is just to, again, because you're responsible for the whole kit and caboodle, at the end of the day, at the end of the trial, at the end of the data collection, there'll be a place that will show you, or will show your research coordinator, where you sign off and say, oh, I confirm that data collection was done under my supervision in accordance to study procedures, and that the data are accurate to the best of my knowledge. Click, save, done. That's the chart, then it gets closed, and then we're able to work with it to clean it and generate queries and finalize it. So that is the end of that section. I'll ask Maureen to stop the recording, and